Hi, my name is Kaiyuan Xu. I recently graduated at University of the Pacific, and today I would like to share an interesting case that was treated under the instruction of Dr. Joorok Park. A 14-year-old Hispanic female presented to us with a chief complaint of wanting to fix her crooked teeth. In the initial examination, she reported a finger-sucking habit since infancy and a tongue-thrusting habit for years. Extraordinarily, the patient presents with a convex profile, increased lower facial height, mentally strain, and reverse smile arc. The clinical photographs indicate a Class II Division I malocclusion, with a focus Class II on the right and end-on Class II on the left, less than 3 mm crowding of the maxillary and mandibular arches. The patient has anterior open bite from canine to canine with overbite of 0 to -5 mm and overjet of 9 mm. The mandibular dental midline is off to patient's right about 3 mm. The pre-treatment panoramic radiograph shows relatively short ramus and sufficient alveolar bone support in the maxillary and mandibular arches. All third molars are present, with the maxillary ones tipped mesially. The cephalometric analysis indicates a Class II skeletal pattern with ANB of more than 8 degrees and a retrusive mandible with SNB of 77 degrees. She has a steep mandibular plane angle with MP to SN of 43 degrees. Her maxillary incisors are proclined with upper one to SN of 118 degrees, and her mandibular incisors are also proclined with IMPA of 100 degrees. Both her lips are ahead of E-line, with upper lip to E-line of less than 1 mm, lower lip to E-line of 3 mm. The patient's cervical vertebra maturation is at stage 5, and her remaining growth is estimated minimal. The following treatment options were offered. The first option included full fixed appliance for orthodontic treatment, consult tongue habit with the patient, and bound tongue spurs on the lingual surfaces of the maxillary incisors, extract the maxillary first premolars, mandibular right second premolars, and left first premolars, restrict maxillary growth with hypoheadgear, intrude the maxillary molars using microimplants, and correct the Class II with forceps. The second option included a combination of orthodontic treatment with bimaxillary orthognathic surgery. Extract the maxillary and mandibular first premolars to reduce incisor proclination. After pre-surgical orthodontics, default 1 maxillary impaction, along with PCSO advancement and auto-rotation of the mandible, should be performed. If you are interested in how this case was treated, please go to the PCSO Bulletin 2020 issue for more information.